As you know, I'm interested in the human factor and who does the work. And therefore, I'll be talking about the workforce. So I have no conflict of interest, and it's really about starting the conversation. And we know that there by 2040, 67% of annual cancer cases will be in LMIC, and post-pandemic, the progress in declining poverty rate globally has stalled, so we have a lot of challenges ahead of us. Prices are going everywhere up, and cancer treatment is expensive. That's one of the most important things that we all know, and it's not only expensive here in Africa. We know, as you can see in Canada, the rate of spending on radiation therapy and chemotherapy in 2005 compared to 2012 is rising exponentially. And we also know that there's more attention to oncology as the health economy component of oncology, and that the changes in the business of providing cancer care and the technologies have made a profound effect on hospitals and health insurers and on doctors. So even in high-income countries, there's a lot of attention to that. And so why do we treat patients with cancer? Because we want them to live longer and we want them to live better. And there are other ways. What are the ways of looking at value in cancer care? So the ways that we know about is choosing wisely, and it started in the US, Canada, India, and now it came to Africa. And then, of course, I don't know whether you are being taught in your training programs about ESMO scale of benefit, ASCO clinical benefit framework, which tells you whether this clinical trial, this new drug is actually beneficial. So we use certain scales for that. And this is not the topic for today, but we have high-value cares, as Fidel mentioned, as providing the highest quality of care at the lowest cost. And this is what we call the value equation. And of course, Fidel made it a little bit more sophisticated by saying quality minus harm. So I'm going to update my slides. That's where you should always learn from those you taught. And so what are the common quality problems when we practice for care? It's underuse, overuse, and misuse. And so what do we mean by underuse? Underuse is when we fail to provide healthcare services that would have produced a favorable outcome for patients. So try in your clinical practice every day in the clinic to see if you are doing any of those problems. For example, not using neoadjuvant chemotherapy for rectal, breast and bladder, and also not giving the patient enough nausea medications, enough medications for constipation, for pain. So that's called underuse. Overuse is when you provide services under circumstances in which the potential for harm exceeds the potential for benefit. And so, such as giving chemotherapy in the last months of life, or overusing chemotherapy in hormone receptor positive breast cancer, and also overuse of supportive care measures like giving growth factor support when there is low potential for neutropenia. Misuse, which sometimes people think about a lot, is when there's an appropriate service and an appropriate patient, but you have done nothing to prevent a complication that might happen. So the patient does not receive the full benefit of the service. So example, avoiding complication of surgery, so doing a very good surgery with very poor post-operative care. And that's called misuse, not adjusting for renal or hepatic dysfunction when we are giving chemotherapy. And so Verna and I were at Maputo Aortic Conference, and we tried to come up with a list as part of how we spend our time, I guess, socializing. So one of the some of the examples is we are not using, for example, a lot of olanzapine for nausea vomiting. We're not giving you adjuvant chemo for rectal cancer, and when you are giving cisplatin and the patient is getting weaker, you may not be checking magnesium and potassium because it affects their electrolyte, and that can result in cardiac, muscle weakness, and all of that. So the little things, they might look little, but they're very important for the quality of life and for continuation of therapy and for the outcome of therapy. Overuse, we mentioned some of it, but for the sake of time, the bevacizumab in breast cancer. And that's one of the issues that have been noticed and studied. Sometimes when a drug is approved by the FDA in the US and starts to come to Africa or India, and then 3 years later it does not improve survival, and the FDA takes it over the list, the finding is that it is still sometimes being used in Africa and in India. Part of it is marketing by pharmaceutical companies, and other fact is that the lack of update on new evidence. So these things are to look at. And then, of course, misuse which is using capecitabine in patient with MI, not giving HER2 when the ejection fraction is very low, and palliative chemotherapy at the end of life. And so what is the harm of overuse? It's harm at the level of the individual. So families and patients, direct harm, physical, financial toxicity. There is a harm to the hospital and health system and organizations on time, cost personal resources, overburdened emergency rooms, and then macro at the level of the society, as was mentioned by my previous colleague, surgery, where that these resources could be used to prevent cancer and do much more to improve outcome. And then also, when you provide poor quality care, it generates lack of confidence in the system. So what happens when the patients do not trust the system, they know when they go to the hospital, they're going to get a lot of complications, chemo is going to be difficult, is that they may not seek care. Sometimes patients associate going to the hospital, getting chemo at the end of life with death. So they blame the chemo. And they bypass care, over-reliance on private sector, and medical tourism. And a weakness of and sometimes part of it is weakness of the primary care system and huge impact on prevention and early presentation. So as you can see, there's a lot of money lost to medical tourism. This was from The Guardian when the Nigerian president went to get medical care outside Nigeria. And we know what most doctors working in the UK and in the US, they are Nigerian. So we're losing a lot of money to medical tourism. The waste is when we waste resources, it could be because of failure of care delivery, failure of care coordination or treatment, pricing failures when the government doesn't negotiate good prices. African government should come together and negotiate as one unit rather than Tanzania separately from Kenya, from all of that. And then, of course, there's always the risk of fraud and abuse. And we can look at improve quality by decreasing cost. So right now, this conference is part of it, is that we're seeing this conference is not about how to treat breast cancer or what kind of chemo to give or what kind of surgery. We are seeing more attention to financial toxicity, to out-of-pocket expenditure, catastrophic expenditure. And by the way, it's not only for the poor. The African middle class is an emerging middle class. Teachers, even doctors are still maybe upper middle class. But the African middle class is still weak. We still take care of our relatives in the village. We still have a lot of expenditure. So we can slide very quickly to poverty and catastrophic expenditure if we are spending a lot of money on care. And so that's something to remember. It's not only the poor, even the middle class can suffer. And we know that there are economic benefits of scaling up coverage. So this, for the sake of time, I will not go over this, but I encourage you to read the WHO 2020 report on cancer, on value for money, about economy, efficiency, and effectiveness. And so, what does the workforce? What can we do? We can increase the value for money. We can also decrease the value for money. And this is the list of choosing wisely, which is one way of, if we practice it, we can increase the value for money. And remember, it's a tool to start conversations with patients and families. So I will remind you about that. And evidence-based care, Verna talked about that, so I'm not going to repeat it. It comes from getting a proper history and physical, assessing for toxicity, taking accurate diagnosis, following guidelines and value-based care, and talking to the patients, patient counseling, including intent of treatment. Because sometimes you can go around in the cancer center, even also in Canada, sometimes the patients do not know whether the intent of treatment is curative or palliative. They think that cancer is going to go away, and that has a lot of implications for end-of-life care. So there are many reasons that patients in a given healthcare system do not receive evidence-based care. So it's not always the fault of the doctors or the nurses, but there are two ways that we need to remember in which we can fail as physicians and nurses and other healthcare providers in providing evidence care. It's called the two gaps. Okay? These two gaps, one is the no gap, and the other is the no-do gap. The no gap means we don't know. We don't know what is the right thing to do. And this is because of inadequate training. Maybe you're not trained very well. Inadequate access to training materials, because you cannot be taught everything in the program. It's just too much, and inadequate so you need to be a self-directed learner. So, and these, all doctors and all healthcare professionals need to that. And so you need to develop those skills, and sometimes you need to be trained how do you become a self-directed learner, access the information and make sense of it, especially now that information is ubiquitous. Information is available on the internet. Everything is there. But how do you translate it to the bedside? And then also lack of motivation, laziness, negligence, and also lack of system level intervention and monitoring of medical competency. Do we have the medical college? Are they making sure that all the doctors who are practicing out there, are they up to date or not? Are there exams every few years, or even for the consultants? Or is CME being monitored? So each country has different ways, but there should be some regulatory mechanisms to make sure that people are still competent. And then the no-do gap. The no-do gap is when you know what to do, you know what is the best evidence, I know what is the right treatment, but I don't do it. I don't give it. And part of it, the most important reason is high volume clinics and high volume workload. This is why the number of physicians and nurses is very important, because if the more shortage, the more, if I see 60 patients, I'm sure going to miss a lot of important things. I'm not going to give the right treatment or the right supportive care, even though I know. And then inadequate quality monitoring and metrics, so guideline concordance. Do we go around and look at and audit all our charts and see if these patients get the right chemotherapy? Did they get the right follow-up? What are the mechanisms for us to do that? And then, of course, there could be lack of motivation, laziness, negligence, and outright corruption sometimes can happen, especially as cancer therapy is very expensive and people can make money out of it. And also inadequate training in communication, professionalism, and humanism. So this is the no-do gap and the no gap. So try to remember the difference between these two and address them when you are as in yourself as a working physician, as a trainer, and also as part of the health system. And so that's what the WHO meant when they talked about what do we need for education. We need quantity, the right number of doctors. We need quality, they need to know what they're doing. And we need relevance, means that they can actually practice in the country that they are trained for. And recently, this was updated in the Lancet when the Commission on Health Professional Education was updated by Julio Frank, and the group divided the competencies into foundational competency, specialized competencies when you become a medical oncologist, for example, and then integrative competencies for everyone, which include critical thinking, creativity, emotional intelligence, ethical deliberation, and communication proficiency. We did a study that we actually published in eCancer, so thank you, eCancer. And we looked at, preparedness for practice among oncology trainees. And we had trainees from high-income countries and low-income countries, and we asked them a lot of questions about, can you provide survivorship care? Do you feel comfortable providing supportive care? And most of them were like, it was really very honest, but the lowest confidence I have was in leadership, effective management of an oncology practice, and understanding healthcare system in both LMIC and HIC. And they wanted to have an instruction on cancer system, leadership needs. They need to be incorporated in all training curricula. So I'm going, because of the sake of time, I'm going to skip over this a little bit, and I'm just going to say that most curricula, and that's what Nazima talked about, are trying to teach that. The competencies themselves, most of the time, are not spelled out. We have more syllabuses and actual competency training. And so how is it taught? Is it assessed at the level? So if this is the ASCO global curriculum, and they want you to be able to determine highest value agents, and there's awareness, knowledge, and skills. So that's something the trainees can look at and see what do they need. Competency-based medical education, what's competency is a habitual and judicious use of communication, knowledge, technical skills, clinical reasonings, emotions, values, and reflection in daily practice for the benefit of the patient and the community. And so this is actually a new concept. So even in Canada, so this is the US, they created milestones and competencies. So one of them is identify key components of the complex healthcare system, barriers for individual patient, and financial components. So that becomes a component, and then you kind of assess it as you go along with milestones. So that's new in the US. That's new in Canada. We started it in 2018. So we are not behind in Africa at all. Actually, might be easier for us to actually establish competency-based medical education, and we see it in nursing. So, for example, this is from South Africa, some of the competency programs. So, really, what is the difference between knowledge and competency? So, I will give you an example. A resident who is knowledgeable can describe to you how the clinical trial is done. But to get to the level of competence, this resident can critically appraise, can tell you, is this benefit real, or is it just like 2 months, adding, or the statistics are wrong, so that you get an impression that the patient will get more benefit. And so that's how you get stewardship of resources. And the advantages of competencies is that sometimes it allows for defining progression, it facilitates selection of assessment tools, but requires a lot of work, requires faculty development, requires realignment of accreditation. And so, for example, in Kenya, the task force, the health, Minister of Health wanted that the role of function of medical specialists are not well appreciated, okay? Such as medical oncologists, and wanted them to use the CAN-MED roles. Anyone familiar with the CAN-MED roles? Competency, like expert, medical expert, advocate, leader. So these are some of the competencies that some programs use. For example, Kenya, they want them to use that. Research, what is the role of the oncologist, for example, research, policy formulation, leadership of institutions and standards. I will skip over the CAN-MED roles, But putting it together when you are training in your program, identify abilities you need. What is a graduate do I need? Identify the competencies, define the progression. What do you want the first year resident to be like? What do I want my second year resident to be like? The third year resident, select the assessment tool and evaluate the performance of the whole training program. And then there are strategies in the clinic to increase the use of evidence-based medicine. And these include evidence-based medicine, ensure guideline concordance, ensure critical inquiry, encourage incorporation of value in cancer care, recruit knowledgeable non-clinical faculty for didactic teaching, research and quality assurance, and make use of online tools. And we have, Nazima has participated in some of our master class in critical appraisal at Queen's, and these are open for all African trainees, so hopefully that could be done. I think I would go ahead and finish. I just want to mention that the Cancer Moonshot, which was started by President Nixon in 1971, was about generating new treatments for the war of cancer. And then our colleague Bishal Gwali came up with the Cancer Ground Shot in 2017, in which he said it's about using what we have, making the best out of it, what we already have before we get the new treatment. Hopefully, that's something we will talk about in the future. I will, for my last slide, I will say we need humility, we need humanism, and we need professionalism, because our patients know more about their values and their lives. They are vulnerable to information asymmetry. What does that mean? As doctors, we know more about the chemo, with the staging, the surgery, and our patients don't know much. So we need to respect that they're not doctors. So this information asymmetry gives us power, and power need to be used wisely. And new drugs and new technologies are not always better. And just this is Khartoum at night. So we need to come together and do that. This is the White Nile meeting the Blue Nile to form the Nile. And so that's one from Ethiopia, one from Uganda, and probably some origin in Tanzania, all the way to Egypt, because of the strengths of Africa coming together. And as one of my favorite heroes, Lumumba, African unity and solidarity are no longer dreams, they must be expressed in decisions. So I think the Choosing Wisely movement should be a continental movement, and we should put our mark on the world. Thank you so much.